So just thrilled when Hallie contacted me. I've heard of Hallie for years, and we just met for the first time today. So Hallie is one of the leading figures, particularly in critical care. And she does this absolutely fantastic work on sepsis control, leads one of the Michigan collaboratives. So I couldn't be more delighted to have Hallie speak this evening, and really, really looking forward to hearing her talk. We're being joined online by over 100 people, and we've got about 40 here in the room as well. So a great talk awaits us. Thank you very much, Hallie.
Awesome. Well, thank you. Thank you to Mary for having me here. And thanks, honestly, to everybody for coming out for an in-person talk and joining online. It's really a pleasure to be here, and looking forward to sharing some work about the Michigan collaboratives and hearing questions and feedback at the end. In terms of conflicts of interest, I have no financial conflicts. A lot of the work that I will be sharing today is funded by either Blue Cross Blue Shield of Michigan, which is an insurance company in the state of Michigan, or the Agency for Healthcare Research and Quality in the US. And then in terms of sort of academic conflicts, I serve as the incoming co-chair for the Surviving Sepsis Campaign Guidelines and lead this statewide sepsis initiative that Mary mentioned. I'm also an employee of the U.S. Veteran Affairs Healthcare System, so just obliged to tell you these are my views, not necessarily government views. So in terms of outline, I'm going to give some very high-level background. Why sepsis? Why is it important? Background on me, where I work, my research focus. I'll do a brief patient case, and then I'm going to dig into literature about antimicrobial timing for sepsis, diagnostic uncertainty, and how we try to give antibiotics quickly when we struggle to diagnose sepsis in real time, and sort of how we build those into performance improvement guidelines and bedside care. So, what is sepsis? Our most recent consensus definitions are that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And I think it's always important to recognize that this is sort of a work in progress, and that this term sepsis has been around for thousands and thousands of years, shows up in poems of Homer, writings of Hippocrates. So when I teach sepsis to the medical students, I describe it as this sort of threshold on this broad spectrum of interactions between host and microbes. So on the far left, microbial colonization, we have lots of bacteria that live on and within us, and we happily accept those, and they're helpful. As we move across the spectrum, there's infection. This is when the body views this microbe as a problem, classical signs and symptoms of infection. And then we pass some line in the sand, some threshold where the body's response to this infection now becomes injurious. And that sort of fundamentally is the focus of sepsis. And I think we just sort of continue to refine what is that line in the sand and how do we define it. Sepsis is a really important problem, very common, about 50 million hospitalizations around the world annually. It's a major driver of inpatient hospital mortality. It's estimated to contribute to about half of all hospital deaths in the US. And then among patients who survive hospitalization, sepsis results often in substantial new morbidity. So it's associated with cognitive impairment, new functional limitations, health deterioration, and increased risk for mortality in the weeks, months, and even years after sepsis hospitalization. Finally, as a result of this health impairment, only about half of patients who are employed prior to sepsis are able to return to work afterwards. So overall, sort of big public health importance to sepsis. So what do I do? My career and sort of research has really been focused on improving long-term outcomes from sepsis by upstream improving care practices across the continuum from hospital presentation all the way out to outpatient follow-up. And there's a variety of sort of tools in the toolbox that I use to do this. Sort of at the base is rigorous observational research, involvement in clinical practice guidelines, and then performance evaluation and quality improvement work. So where do I work? I have a joint appointment. I work at two different hospitals. So I work at the Ann Arbor VA healthcare system, which is a small, maybe 115 bed hospital, and is part of our nationwide veterans healthcare system that serves about 6 million veterans annually, which is the largest integrated healthcare system in the US. And then the other kind of half of my work is at University of Michigan, which is a large tertiary academic medical center with about 1,000 beds. So clinically, I do about a month of ICU in the VA and about 2 weeks at the university. And then I have a sepsis research program that sort of spans both half of this, both hats that I wear between the VA and the university. I've been fortunate, I'm on sabbatical this semester, and I've been in London working at ICNARC, which is the Intensive Care National Audit and Research Center, and learning about their audit of ICU stays and how we might take that back and, use some of the sort of rigorous work that they do to sort of further refine our registry and audit of sepsis hospitalizations in Michigan. My sepsis research program largely leverages nationwide electronic healthcare records for the VA system. Everybody's on the same electronic healthcare record system, and there's about 130 different hospitals. So it's very interesting to sort of understand and study the variation across this very large system, all in the same health record system. And so I have two kind of large ongoing grants, one looking at antimicrobial prescribing patterns, and the other looking at recovery practices for veterans going home after sepsis hospitalization. On the university side, most of my non-clinical effort is spent on hospital medicine safety. This is the collaborative quality initiative that Mary was mentioning. So Michigan has this long sort of history, about 25 years now, that Blue Cross has been funding these collaborative quality improvement initiatives that typically focus on a sort of a specific topic. So most of them are focused on specific surgical procedures, bariatric surgery, joint replacement, cardiac surgery. But hospital medicine safety was founded in 2010 to improve the care of hospitalized medical patients in the state of Michigan. And under this kind of umbrella, there have been a number of different initiatives over the years: DVT and PE, treatment and prophylaxis, antimicrobial stewardship, and sepsis is the most recent initiative. And that's where I got pulled into this kind of amazing environment of these collaborative quality initiatives. So our sepsis initiative started January of 2020. Things were a little bit rocky in the beginning, as you can imagine, with COVID, but we've now sort of rolled out and have data collection at 69 hospitals across the state that we collect data on. The funder is Blue Cross Blue Shield of Michigan, which is this large employer-based insurance company. They fund our coordinating center, and they also provide direct funding to all of the participating hospitals for them to then hire a data abstractor, and also some effort for actually doing quality improvement locally in those hospitals. So what are the things that we measure? I think so we broadly focus on structure, processes, and outcomes, the three pillars of quality improvement. We assess structures at hospitals through a biannual hospital survey where we ask about things like staffing, critical care capabilities, policies, and protocols related to various things that relate to sepsis treatment. In terms of processes, we collect that through data collection at the hospitals that goes into our registry. And we're currently focusing on about 26 different processes that are organized into 4 different bundles. And these span from early sepsis care all the way to peri-discharge care. So, is there appropriate medication reconciliation? Are they being scheduled for timely follow-up after they leave the hospital? And so I think that's something that's a little bit unique about this initiative, is the focus not only on these kind of very, early first 6 hours, but trying to, promote a sort of better recovery and transition to the outpatient setting for patients. In terms of data outcomes, we collect a variety of data on our patients through data linkages, chart abstraction to see if they've been rehospitalized at that hospital or other surrounding hospitals. And then we also collect patient-reported outcome measures by telephone, text message, email to patients after discharge. And so we get things like disability using the World Health Organization Disability Assessment Schedule, return to work, and financial outcomes. And the other side of the work that we do in this collaborative is really trying to, what I would say, nudge performance improvement at these hospitals. So we do the data collection, and we use this to do audit and feedback to our hospitals. So they get a quarterly performance report. We have live reporting, so they can go on, sort of look at data as it accrues in real time at their hospital compared to other hospitals, and fallouts. So patients who didn't meet the performance metric that they can then, look at for their own quality improvement, or also giving us feedback. If they say, well, gosh, you said that this didn't meet the target, we think care was appropriate. And so we are sort of continually refining the data collection and sort of how we analyze that data in response to the feedback that we get from the field. We do a lot of sort of sharing of tools and resources. So we will identify high-performing hospitals. We invite them to present what they do at our collaborative-wide meetings 3 times a year. And oftentimes that will include sharing of education tools, documentation tools, order sets, protocols, that then the other hospitals can bring back to their hospital and sort of incorporate into their care. Finally, there is a performance index that is essentially like a report card that gets made for each of the hospitals. And this goes back to Blue Cross Blue Shield, the funder, and is tied to financial incentives for the hospitals. About half of this performance index relates to participation, so timely and accurate submission of data. We audit the data to make sure that, yep, this is what you abstracted, and that indeed checks out in the medical record. So about half of it is timely, accurate data submission and participation in things like the survey and the annual meetings and sort of being an engaged member of the collaborative. And the other half of this performance index relates to their performance, traditionally on process measures as opposed to outcome measures. So that's kind of a high level, in a nutshell, who I am, what I do. And I'm now going to move us on and do a brief patient case. So this patient is a 67-year-old male, severe underlying heart disease, reduced ejection fraction of 20%, and presents with shortness of breath, difficulty laying flat, leg swelling, productive cough, and fevers. On exam, this patient has a temperature of 37.9, heart rate is 145 and atrial fibrillation, blood pressure 90/65, respirations are 24, and citing 88% on room air. This patient has jugular vein distension, peripheral edema, and scattered rails. Further exam reveals his white blood cell count is 12.5. He's got a mild lactate elevation, mild creatinine elevation, and chest x-ray showing both pulmonary edema and a focal infiltrate. So this patient receives fluid and antibiotics. They're given IV diltiazem, blood pressure drops. This patient proceeds to get sicker and is ultimately admitted to the ICU. So we'll come back to this patient case a little bit later in the presentation. And I'm now going to move on and sort of introduce this topic of antimicrobial timing for sepsis that has been really a key focus, I think, of sepsis quality improvement work and has been pretty polarizing, I think, at least in the US, and I really think I suspect everywhere else as well too. So there's people who think like this is really vital. This is one of the most important things we can focus on to improve sepsis outcomes. And then I think there's other camps of people who think, gosh, this really intensive focus on time to antibiotics is overblown. And more concerningly, by focusing, really so heavily on time to antibiotics, that maybe we're driving antibiotic use across the board, including to patients without sepsis. Prompt administration has been strongly recommended by guidelines. So back in 2016, it was recommended to deliver antibiotics within 1 hour for sepsis and septic shock. This was included in the Hour 1 bundle, kind of further underscoring the importance. And in the US, there's a variety of different performance measures endorsed by our National Quality Forum, as well as policies that try to promote timely treatment. So why has this been such a big focus? There's been data on this issue, I think, dating back to about 2007, sort of a classical paper by Anand Kumar showing every hour of delay led to 7% increase in mortality, almost certainly an overestimate. But there have been other larger studies that have come out recently that continue to bear out that there is this association between time to treatment and mortality. This was a study done by a collaborator of mine at Kaiser, Vinnie Liu, and they looked at 35,000 patients in their system, looked at time from ED arrival to treatment, and found that with each hour of delay, there was this increased risk for mortality, and it's particularly strong in patients who are sicker. Oftentimes, patients who are in shock is how that's assessed in these studies. It's important to recognize this is a very large study, about 35,000 patients, and a fairly high mortality population, so 26% in-hospital mortality and septic shock. I was part of this other study. This was very similar, came out around the same time, and this looked at our New York State data. There was a statewide initiative. All the hospitals had to submit data on their sepsis treatment and outcomes, and we likewise used this data to kind of answer the same question. Similarly, very large study, 50,000 people, pretty high mortality cohort, and similarly finds that there is this association, and it's much stronger in patients with shock. There are certainly some limitations to this literature. So critiques have been written on this kind of whole body of observational literature about focusing on post-hoc sepsis cohorts, focusing on sicker patients, inclusion of patients with very long delays might inflate these estimates, and that there's certain things that are really challenging to control for in our studies, like how obviously a patient presents with infection. The more obvious it is, the more likely they are to be treated, and maybe those obvious presentations have better outcomes. So I think certainly there are some limitations to this observational literature. There's been one clinical trial to date that has addressed this issue. This was a study of patients in ambulance with suspected sepsis en route to the hospital, and they were randomized to getting antibiotics right there in the ambulance versus being taken to the hospital and getting treated there. This resulted in getting antibiotics 96 minutes faster and resulted in similar mortality. So 0.4% absolute mortality reduction in these patients who got treated in ambulance earlier. And so I think this has led to a lot of, well, gosh, is all the observational literature wrong? Why do we see a null effect in this trial? And my interpretation has always been very different. So I highlighted how those prior studies were very large, much higher mortality population, many more patients in shock. And this is 2,600 patients, only 3% in shock, and a 28-day mortality of 8%. And so if you take those relative risk reductions from those observational studies and you apply it to this very different population, exactly what you'd expect to find is about a 0.4% mortality reduction, which they saw. So my interpretation has always been this is very consistent. And recently they've done a secondary analysis and sort of interestingly showed that when they account for age, in the younger patients under about 70, there is a significant mortality reduction in this very same trial population. There are a few trials, I think, coming on board for this topic. The Pit Stop trial is being run in Ontario, and this will enroll 2,000 patients, all of whom are hypotensive. So really trying to hone in on these sicker patients. And then there was also a pilot study done in Wales. There was a feasibility study about doing the same idea of identifying people in ambulance and treating them en route to hospital, and met progression criteria. So I believe is in process to becoming a clinical trial powered for patient important outcomes. So summary of what we know, time to antibiotics has been pretty consistently associated with improved survival, and this association is stronger in sicker patients. Fantasy trial has often been thought to be, maybe contradictory, but as I explained, I think that it's really consistent with the observational studies. And there are certainly limitations to the data that I pointed out, but the findings are pretty consistent, and there's been a lot of studies on this topic besides the one that I have mentioned here. So how do we take this into account with diagnostic uncertainty? This is where I will take you back to the patient vignette. That patient vignette was a sort of abridged version of a patient vignette that was part of a survey of intensivists, where they were asked to classify this clinical presentation as being SIRS criteria, sepsis, severe sepsis, septic shock, or none of the above. And intensivists came down all over the place. So a third of them said, nope, none of those things. A third said, this is septic shock. And a third kind of came down on SIRS, severe sepsis, sepsis. So showing like we really struggled to diagnose this. Even when they dichotomized, severe sepsis, septic shock versus not, very poor agreement. And then even when they further honed down to those who reported they were highly confident in their assessment, still very poor agreement. So they concluded this is subjective, it's variable, we need better objective criteria and standardized methodology to enhance consistency and comparability in sepsis research, surveillance, benchmarking, and reporting. It's a vignette study. Obviously in real life, maybe you'd order a few more labs, you'd go back, you'd talk to that patient some more. But there's a number of studies that show the same issue happens in real world clinical practice. So these are 3 different studies that were done looking at cohorts of patients who presented to the emergency department or were admitted to the intensive care unit with this essentially label or tentative diagnosis of sepsis. And then they ask at the end of the hospitalization, when all is said and done and all the information that's kind of subsequently been learned is known, how likely was it that this patient truly had sepsis or a bacterial infection when they presented to the ER and to the ICU? And across these studies, they find that about a third or more of these patients, turns out that this diagnosis is deemed unlikely in hindsight, that probably it was, a non-bacterial infection or not an infection at all. And so diagnostic uncertainty or diagnostic disagreement is common for sepsis, and about a third of these cases may be overturned. And so this issue of diagnostic uncertainty, I think, has really raised a lot of concerns that by focusing on earlier time to treatment, we're driving overuse, we're driving antimicrobial resistance. And so these are just a variety of different viewpoints, editorials, perspectives that have kind of raised attention to this issue. And they all come down to this same conclusion that time to antibiotic targets risk overuse and risk antibiotic associated harms. So in the US, this became such a widespread concern and fear. American College of Emergency Physicians and several other professional societies petitioned our National Quality Forum, say you need to de-adopt and de-endorse this severe sepsis bundle that forms the backbone of all of these kind of state and national performance improvement programs. And their key recommendation was that really we should just be focusing on septic shock. And their rationale for that was that that's where the data, as I kind of have shown, is stronger. That's where the association is stronger. Ultimately, National Quality Forum re-endorsed the severe sepsis bundle as it was, but nonetheless, there was and continues to be a fair amount of controversy related to this. And so I think this brings us to this urgent unanswered question of, well, is this focus on early antibiotics actually driving overuse, right? The data about time to treatment is certainly not perfect, but it's consistent, and there's a lot of the literature, and they all show that there's an association. And while there's a lot of concerns about driving overuse, there's very little data about whether that's actually happening in practice. And so Vinny and I, who had both sort of been contributors to this literature about the impact of time to antibiotics, kind of felt an obligation to say, what's actually happening when hospitals shorten time to treatment? Is there associated change? Is there rising antibiotic use or broader spectrum of coverage among this much larger population of patients who are at risk for sepsis? And so this work has been funded by the Agency for Healthcare Quality and Research. And so in this study, it's a large study, so we leverage these nationwide VA hospitals as well as 22 hospitals in the Kaiser system. The exposure in the study has been the hospital-specific trend. So what is happening in an individual hospital over time in terms of how quickly they treat hospitalizations that meet our surveillance criteria for sepsis. And we had about 273,000 hospitalizations that met criteria for sepsis. And then for the outcome, we measure that again in these at-risk patients who are at risk for having the spillover or excess antibiotic prescribing. And that was measured in this broader population of patients admitted through the emergency department and have positive SIRS criteria on presentation to the hospital. And so we had a very large population of about 1.6 million hospitalizations over the 6-year period, 152 hospitals. So in terms of measuring the hospital trend and time to antibiotics, so we got very in the weeds, and we're measuring barcode medication administration times. These are essentially the timestamps for when the nurses scan the barcode of the medication, scan the patient barcode, and then deliver the medication. So I think pretty as close to ground truth as it can get. All the hospitals had that for patients admitted, but penetrance was incomplete in the emergency departments. And so for patients who received antibiotics in the emergency room, we used the order entry time plus a lag time of 45 minutes, but did a number of sensitivity analyses around that. So that was how we estimated for every patient, regardless of where the antibiotics were first delivered. We had our best estimate of what was the time to treatment. And so we found that overall, this data here is for the VA system, time to antibiotics in sepsis has decreased year on year by about 9 minutes per year. Did a number of sensitivity analysis. How do you model this change? How do you measure these patients for whom you don't have the perfect data because it was given in the ER and the ER didn't use the barcode medication administration timestamp. But across all of these, about 9 minutes per year and consistent year on year. Other findings of this, we found that antibiotics were faster in patients who presented with fever versus patients who presented with hypotension. And that kind of goes back to this concern that maybe there's something about the obviousness with which people present with their infection. And is also somewhat concerning because all the data suggests that it's the hypotensive patients, the sicker patients for whom it's particularly important. And there's some evidence here that those patients aren't necessarily being sort of prioritized for their evaluation. Another major finding was that there was meaningful variation across the hospitals, even after sort of very careful adjustment for how people presented, their ages, their comorbidities, their physiology on presentation to the hospital. The median odds ratio for receipt of antibiotics within 3 hours among patients who presented with sepsis was 1.65. So that means that if you take two sort of hospitals selected at random, you transfer a patient from a slow to a fast hospital, there's a 65% increase odds that at that hospital they get antibiotics within 3 hours, but not at the prior one. By contrast, presence of shock was this, every individual patient factor was less strong than this hospital effect. So to me suggests that we still have some potentially unwarranted practice variation across hospitals, even though kind of across the board times are going down. The final important finding of the time to antibiotic analysis was that the slope of change varied across the hospital. So we have a group of hospitals that are having much steeper declines, some that are having, sort of more mild declines, and a number of hospitals that are kind of flat. And that's helpful for being able to leverage that variation to understand how it relates to other aspects of antimicrobial prescribing. And so we led this analysis to really kind of answer the crux of the question of when hospitals shorten time to treatment, what happens? And again, leveraging the variation in those hospital-specific trends to see how do they associate with hospital-specific trends and how many people get treated at all? What's the average days of therapy? What's the broadness of coverage that they receive for those antibiotics? Trying to ask, is it associated with overuse? Or if everybody's actually declining, is it impairing stewardship efforts? So it's slower pace of stewardship progress. So overall, across this 152 hospital cohort, these are the trends for antibiotic use in our SIRS-positive hospitalizations. A greater proportion of patients were treated with antimicrobials within 12 hours, but then you zoom out and you look at the cumulative proportion treated within 48 hours, and you see that there's actually a tiny bit of a decline. Days of therapy on average, inclusive of antibiotics prescribed at discharge to complete at home, went down, I think, markedly, a 0.5 day difference on average for, again, all of these SIRS-positive patients. And then consistently across a variety of ways of measurement, the use of broad spectrum antibiotics has decreased over time. So I think for like overall across these hospitals, very positive findings that stewardship was also improving during this time. And so then now we ask, how do these hospital level trends correlate? And the kind of high level answer is that there was no relationship between what was happening with time to antibiotics and sepsis and what was happening with that stewardship trend. So we looked at a number of outcomes. We measured different ways of kind of trying to associate these two trends over time and found no relationship between them. Here is a visual example of one of these trends. So in this scatter plot, each little dot represents one hospital in our cohort. And so on the x-axis, they're plotted about what is their yearly average change in time to antibiotics. So this would be no change at 0. And as they go further to the left, that means they've had steeper and steeper sort of declines or shorter time to treatment. And on the y-axis, we look at the change in mean days of antimicrobial therapy among this whole population of SIRS-positive patients. Again, here is 0. You see the vast majority of hospitals are below 0. They're all bringing down antimicrobial use. And then in green, I've highlighted the hospitals that are sort of exactly where you want them to be, right? For hospitalizations that meet surveillance criteria, time to antibiotics is going down, but simultaneously their overall use of antimicrobials is also going down. And so this in total, about 85% of the hospitalizations are making simultaneous improvements across both of these domains, which I think was a really kind of positive message. I think stewardship and sepsis have often been seen as these kind of opposing forces. You know, you can't improve both of them simultaneously. And this study, I think, really showed that, well, actually, most of the hospitals seem to be doing just that. So that's pretty good. So, overall summary, right? Time to antibiotics went down among the SIRS positive across multiple different measures, use, days of therapy, use of broad spectrum coverage, all those going down, and these trends are not correlated. So no evidence about this kind of big worry about driving indiscriminate use or impairing stewardship. Key limitation I think is worth mentioning is that both VA and Kaiser are very large integrated healthcare systems. They have invested heavily in antimicrobial stewardship programs. So it's not like this was just, nothing was being done there. And so again, it's possible that may not reflect all hospitals. Nonetheless, I think given how much was written about, oh my gosh, rampant antibiotic overuse is being driven all around us, I think that this did provide some reassurance that it's possible to do both of these things well. All right. So what are the implications of these findings? So how do we sort of take this literature and apply it to our bedside care? How do we bake this into clinical practice guidelines? And how do we use this data to measure performance in the Michigan Collaborative? So in terms of implications for bedside care, this is a figure from a perspective I wrote a few years back about, how do you do this in clinical practice? And it really talks about making decisions across two axes. One, how sick is this patient? The sicker they are, the quicker you make a decision. And sometimes you need to treat with skimpier evidence because the risk of being wrong is too high. On the flip side, when the patient is not ill at all, you have more time and you should take more time and you should be very convinced and sort of know that this is a bacterial infection before initiating treatment. So sort of taking the overall likelihood of bacterial infection and the overall summary assessment of illness severity and using those two axes to guide your care going forward. What about for guidelines? How do we take these two somewhat opposing literatures that time to treatment matters, but we know diagnostic uncertainty and antibiotic overuse is common? How do we incorporate those two things into our guidelines? So I mentioned earlier that in 2016, there was the statement that just everybody should get treated within 1 hour. And I think that was challenging to implement in practice because people would say, well, gosh, maybe they're septic. I only have an hour. I better give antibiotics. And I would have, trainees present to me, well, the patient had a fever overnight, so we gave antibiotics, maybe they have sepsis. I don't really know. And so this new framework that's in the 2021 guidelines is trying to move towards this risk-based assessment and moving treatment accordingly. So over here, it stratifies patients by sepsis is definite or probable versus sepsis is possible. And so if sepsis is definite probable, you're pretty convinced that this is the diagnosis. Just like before, the guidelines say administer antimicrobials immediately, ideally within an hour. If sepsis is possible, however, this then becomes stratified by how sick the patient is based on are they in shock or not. If they are in shock, the recommendation is to give antimicrobials immediately. Of course, continue to assess for infection or not and stop the antibiotics if it turns out to be something else. But the new, I think, sort of headway in this guideline is this statement that for patients where sepsis is possible, shock is absent, meaning they're less acutely ill, the recommendation is a rapid assessment of infectious versus non-infectious causes of acute illness. So I think you can now say the guidelines are specifically saying sort of take a deep breath, get the additional data that you can. 3 hours, there's more labs, there's more history, there's more imaging that could be done. And I think this really opens the door to also doing more research. I think in terms of what we really need is kind of more point of care testing to kind of rule in or rule out infection. And I sort of get worried that if everybody said, oh, got to treat in 1 hour, that it really closes the door and sort of limits your ability to even study this, what I think is still a thorny issue of, well, how do we know that this patient has infection? Our cultures take days to come back. So I think there's a lot of work going on now in this kind of point of care testing, biomarkers, trying to do better diagnosis for patients. After this talk went out, I was also emailed this statement on initial antimicrobial treatment for sepsis. So this is the guidance for the UK. And I think this is really cool too. So this similarly stratifies patients not merely by shock or not, which is a pretty blunt instrument, but stratifies them across this NEWS2 score. And then similarly stratifies them by how likely it is that this patient has sepsis or a bacterial infection, and then likewise sort of organizes treatment accordingly. So I thought this was a really nice table, and I understand is getting incorporated into NICE guidelines for the UK. All right, the final bit is how do we think about this for performance assessment and quality improvement? So certainly leading this sepsis quality initiative for the state of Michigan, I spent a lot of time trying to think about how do we kind of nudge care in the right direction, trying to make, improve care and not have unintended consequences. So I think there is good data that antibiotic timing matters. there was that recommendation from American College of Emergency Physicians to just focus on patients in shock. And I really worry about doing that, because I think that while those are certainly the sicker patients, they're the tip of the iceberg. And it's a huge kind of loss of an opportunity to not focus on all of these many more patients with sepsis. And so I do think that those are still an important population for quality improvement work, and there's a loss if you don't include them. I think that it was reassuring that we were able to show that this, reductions in antimicrobial timing were not associated with market spillover. But of course, we always need to be kind of mindful of that potential consequence. So what do we do in HMS? So we measure and report antimicrobial timing for all patients who have non-viral sepsis. So we exclude patients with, positive COVID or flu from this measure. We use time zero as the emergency department arrival. This whole collaborative is focused on community onset sepsis. So they all meet criteria essentially on presentation. And then we target a 5-hour timeline for patients who present without hypotension and a 3-hour timeline for patients who present with hypotension. We also report on time from order to administration, recognizing that's often a big part of the delay and is something that you can actually shorten without having to sort of make the physician make any kind of faster decision. You just need to enact that decision faster. And then we're fortunate because we also have this initiative on antimicrobial stewardship and antimicrobial overuse. And so we concurrently give hospitals a report on, what is their antimicrobial use and is there evidence that they are sort of over-prescribing for things where it wasn't necessary or giving too broad or too long durations. So here's a little snippet of one of our reports. This is for the whole collaborative, not an individual hospital. And so this is our early sepsis bundle, and you can see how we stratify this and report it out. So right now, just under 2/3 of our patients who present with hypotension meet criteria for sepsis, get their antibiotics within our targeted timeframe. And we still see that there's a fair amount of variation around that, about 2-fold variation across our hospitals. So this is an ongoing area of focus for us. We also see that in about 1/3 of all hospitalizations in the state, the lag from putting that order in to actually receiving or initiating that antibiotic is greater than 1 hour. So continues to be a focus for us. So in closing, we have covered that antibiotic timing is associated with patient outcomes, particularly in sicker patients. Some data that antibiotics, however, may be delayed in those sicker but less obviously infected patients. Possible to shorten antibiotic timing without driving overuse, but always important to be mindful. And I think where possible, simultaneously measuring stewardship alongside sepsis trends and outcomes. The guidelines, I think, have come a long way in terms of trying to balance these competing issues and being a little more nuanced in terms of thinking about timing and not just a blanket recommendation for all. But ultimately, I think to continue to move forward, we need better tools for rapid assessment of bacterial infection to kind of get more precise and hopefully bring down this kind of 1/3 rate of diagnostic overturn at the end of hospitalization. So I just want to close with thanks for all of you. Thanks for having me here. Many collaborators, research team, lots of people who are behind this work. And then thanks to my family who's also here with me in England for the semester. So thank you.